Welcome, clinicians. Let's dive right into this explainer. Today, we're doing a real clinical masterclass on treating schizophrenia. Look, in our field, it is way too easy to just fall back on pharmacological symptom management, right? Just prescribe and move on. But, as those of us with miles on the odometer know, schizophrenia happens to a person with a completely unique psychological makeup. So, our goal today is to cultivate a profoundly deep understanding of the patient's internal world. We want to equip you with the nuanced skills to truly meet these patients in the room, exactly where they are.
So here's our roadmap for this explainer. We're going to start with the anatomy of the illness, shift into the psychodynamic lens, talk about building that crucial therapeutic alliance, cover how to tailor our treatment modalities, and then bring it all to life with a complex clinical case study.
I want to kick things off with this absolutely foundational thought from pioneer Harry Stack Sullivan. He said, "There is no developmental period when the human exists outside of the realm of the interpersonal relatedness." I really want you to hold on to that when you're sitting in the room with a patient. No matter how withdrawn, how bizarre, how isolated they might seem to you, their fundamental capacity and, quite frankly, their desperate need for human connection is always there. It's the absolute bedrock of the work we do.
All right, part 1, the anatomy of the illness, progression and symptomatology. Our first real clinical task here is to accurately conceptualize the trajectory of the disease itself, right? Because we have to know exactly what we're looking at before we even think about intervening.
Take a look at this typical chronological sequence. It tracks the illness all the way from childhood premorbid difficulties right through to those long-term chronic phases. Now, why does mapping this trajectory matter so much to us? Well, it's because your interventions literally must be rigorously attuned to the specific phase the patient is in. A very common rookie mistake is applying a one-size-fits-all approach. You absolutely cannot treat a patient who is in the florid, acute psychotic phase the same way you treat someone in those stable, chronic years where rehabilitation is the main goal. Timing, as they say, is everything.
When we're evaluating patients across these phases, we break the pathology down into 3 distinct clinical clusters. We're all pretty familiar with the florid presence of positive symptoms, and of course the absence of function we see in negative symptoms, but I really want you to train your clinical eye on this third cluster, disordered personal relationships. The withdrawal, the hostility, maybe the excessive demandingness, this characterological struggle, this is the raw substrate of our psychodynamic work. Now zooming in on those negative symptoms for a second, differential diagnosis here is absolutely vital. You've got to constantly be asking yourself, are the negative symptoms I'm seeing a primary deficit syndrome, like a true structural lack, or are they secondary? Because far too often what looks like blunted affect or impoverished thought is actually a secondary defensive reaction to severe anxiety. Or honestly, it might just be the heavy side effects of their antipsychotic meds. You've really got to play detective and rigorously investigate the difference.
Okay, moving on to part 2. The psychodynamic lens, specifically looking at conflict versus deficit. Let's unpack how psychodynamic theory actually builds our understanding of the patient's internal reality.
It's always fascinating to contrast these 2 foundational ways of conceptualizing the schizophrenic mind. On one hand, you have Freud's early decathesis and conflict model, which basically argued for a total withdrawal of emotional investment from the outside world. But then contrast that with Sullivan's interpersonal model. Sullivan argued that psychosis is essentially a massive panic state, triggered by a disassociated self. And the beauty of Sullivan's model for us clinicians is the hope it provides. It tells us the patient isn't empty, they are just terrified. That capacity to relate is still in there, hiding, just waiting for a safe object.
But look, theory alone isn't going to cut it. We have to synthesize our psychological formulations with the hard neurobiological realities. Genetic vulnerabilities interact heavily with the environmental and behavioral precursors you see outlined here. For instance, think about sensory gating loss. Many of our patients literally cannot screen out irrelevant stimuli. They are living in a chronic, nonstop state of sensory overload. Just imagine for a second how that biological hypersensitivity interacts with a distressed family environment. It creates an absolute powder keg of profound psychological terror.
Which brings us to part 3. The therapeutic alliance, and the concept of offering asylum. This is the pivot point. It's where we take all that theory and translate it into actual practice. It is the absolute cornerstone of our work.
When you pull up a chair and sit across from a patient with schizophrenia, you have to offer true asylum. And to be clear, I don't mean a physical hospital. I'm talking about a psychological sanctuary. You must become a holding environment that can tolerate their profound, projected terror. You literally have to just
be with the patient. Accept the withdrawal. Accept the bizarre behavior, without demanding they change just to make you feel like a competent, successful clinician. We have to completely let go of that narcissistic fantasy of swooping in and rescuing them.
Now, actually building this early alliance is notoriously tricky, mostly due to the patient's lack of insight. So, we need highly practical strategies. One of my absolute favorites here is the technique of treating delusions metaphorically. If a patient is presenting with a fixed delusion, hitting it head-on is just going to destroy trust. Instead, act as an auxiliary ego. You want to ally with their own goals, like, say, staying out of the hospital, by helping them anticipate how other people might react to their behaviors. That way, you keep them safe and you build relatedness, all without declaring war on their internal reality.
All right, part 4, tailoring treatment modalities. Once we have that secure asylum-like alliance locked in, we need to individually customize our specific interventions.
For individual interventions, we often rely on disorder-specific frameworks, like phased personal therapy, which is a great reminder that pacing is paramount. You don't just jump straight into deep introspection on day 1. You have to logically step the patient forward. Initially, it's all about clinical stabilization and basic alliance building. Months later, you might move into the intermediate phase, developing affective awareness and social skills. It's only in the advanced phase, when that patient is truly secure in the community, that you introduce introspection and conflict resolution. If you push too fast, you seriously risk triggering a psychotic relapse.
And when we widen the lens to the family system, your psychoeducation has to aggressively target something called expressed emotion, or EE. This is critical, folks. The research clearly shows that excessive family criticism and intense over-involvement create a highly toxic synergy with the patient's existing neurocognitive vulnerabilities. High E is actually a massive predictor of relapse. By helping families dial down that intensity, reduce their criticism, and spot those prodromal signs early, you are drastically improving your patient's long-term prognosis. It's a real game changer.
Okay, part 5, clinical application and our case study. Let's pull all these threads together by looking at the incredibly complex treatment of Mr. I. This is where the rubber meets the road in the consulting room.
So, meet our patient, Mr. I. He's a 22-year-old man with a 3-year history of schizophrenia, and he comes from a family of incredibly high achievers. He presents with these severe, bizarre somatic complaints, basically pain everywhere. He's deeply paranoid that everyone is constantly ridiculing him, and he adamantly, aggressively refuses antipsychotics, completely denying he has any psychiatric illness at all, while simultaneously demanding constant medical monitoring for these physical symptoms. I mean, ask yourself, as a clinician, where do you even start formulating a case like this?
Well, looking through a psychodynamic lens, it clicks. We see that his physical symptoms weren't just random delusions. They were a really desperate psychological defense mechanism. The mask of somatic pain was actually organizing his thoughts, keeping him from experiencing complete psychotic fragmentation. And the mechanism here is fascinating. He took his parents' intensely high expectations, internalized them as persecuting objects, projected them out into the world as paranoia, and then reintrojected them as agonizing physical pain. And the function of all this? Somatizing was quite literally his only way to maintain object relatedness. Demanding that doctors care for his physical body protected him from terrifying separation anxiety.
So how exactly did the treatment team leverage this formulation? Honestly, pretty elegantly. First, by validating his physical pain experience, suggesting that maybe medication could help his brain filter overwhelming physical stimuli, they totally bypassed his denial without challenging the delusion, and that secured his medication compliance. The nursing staff then stepped in as auxiliary egos, physically checking the hallway to reality test his internal voices, proving no one was whispering out there. The doctor set firm limits on his demands, offering a safe relationship that cared for him but didn't indulge the entitlement. And it was only after all that groundwork was laid that the therapist could use a supportive approach to gently start exploring his deep-seated feelings of inferiority.
I want to wrap up our explainer today by leaving you with a somewhat provocative question for your own practice. As you continue to develop your clinical posture, can you consistently provide sanctuary? Can you sit there and tolerate the profound terror of your patient's psychotic experience? Can you sit with their pain and actually accept their wish to remain ill as a valid alternative to psychotherapeutic change? It's a heavy thought, I know, but true healing in schizophrenia often only begins when we finally surrender our need to rescue or cure, and instead commit to simply and deeply understanding. Thanks so much for joining me today.